My sister's 9 years old and has cerebral palsy. She struggles with motor overflow, regulating her emotions, and also focusing and completing her tasks. Do you know what I could do to help her?
Hi, I'm a physiotherapist, and I use aerobic exercise to help kids just like your sister.
No way. Can you
Let's
tell me
find
more?
out more.
Hi everyone, today our group will be presenting a research article titled Influence of Aerobic Exercise on Inhibitory Control of Executive Functions in Children with Hemiplegic Cerebral Palsy, a randomized control trial. Before diving into the study, let's go over what we'll be covering. We'll begin with some background information on cerebral palsy and what we already know from existing research. Then we'll introduce the study's objectives, the methods used, and the key findings and results. After that, we'll jump into the discussion where we look at the strengths and limitations before making connections to class concepts and looking at future research. Let's start with some background information to better understand the context of this study. Cerebral palsy, or CP, is a lifelong neurological disorder that affects movement and posture due to a non-progressive brain injury occurring either before birth or in early infancy. While the initial damage doesn't worsen over time, the effects of CP can evolve as a child grows, influencing motor function and overall development. Beyond motor impairments, CP is also associated with secondary impairments impacting communication, perception, sensation, behavior, and cognition. One subtype of CP is hemiplegic cerebral palsy, which is characterized by motor impairments affecting only one side of the body. This results from a brain lesion occurring in the opposite hemisphere and affects approximately 1 in every 1,300 live births. The severity of hemiplegic CP depends on the location and the extent of the lesion. However, the impact of hemiplegic CP also extends beyond physical challenges. Many children also exhibit behavioral and emotional dysregulation, making it difficult to control impulses, focus on tasks, and regulate emotions. Existing research has established that children with cerebral palsy often exhibit poor inhibitory control compared to their typically developing peers. Inhibitory control plays a crucial role in daily functioning, influencing a child's ability to regulate their emotions, focus attention, and filter out distractions. Research on typically developing children have found that aerobic exercise can improve executive function. Evidence suggests that this occurs due to factors such as increased cerebral blood flow and the upregulation of neurotrophins like BDNF. Additionally, aerobic exercise in children with cerebral palsy have been found to improve aerobic capacity, gross motor function, and self-perception in adolescents with spastic CP. However, there remains a notable gap in the research regarding children with hemiplegic CP. Specifically, there is limited research exploring the impact of aerobic exercise on addressing executive function deficits in children within this population. Given the limited research in this area, the primary aim of the study was to explore whether aerobic exercise could improve inhibitory control in children with cerebral palsy, and particularly those with emotional and behavioral dysregulation. By building on existing research, the study aims to fill a gap in knowledge specifically related to children with hemiplegic CP. The authors hypothesized that the aerobic exercise will have a positive effect on inhibitory control within executive function in children with left-sided hemiplegic cerebral palsy. Now that we understand the purpose of the study, let's take a closer look at how the researchers conducted their experiment.
So, this study used a single blind randomized control, in which case the researchers were blinded, and it was conducted in outpatient physical therapy clinics. So, 70 children participants were recruited in the study, but only 60 actually enrolled due to not meeting inclusion criteria or simply just declining to participate. In regards to inclusion criteria, the children had to be between the ages of 7 and 11, which also happens to be the age of significant development of executive function and inhibitory control. Of course, they had to be diagnosed with left side cerebral palsy. They also had to be able to walk independently and score a functional level of 1 or 2 according to the gross motor function classification system, which looks at their degree of motor impairment. They also had to score higher than a 28 on the pediatric symptom checklist, which indicates emotional and behavioral impairment. In regards to exclusion criteria, this involved children with visual or auditory problems, as well as children with a history of drug intake that could affect their typical cognitive functioning, and medically unstable children, so those with cardiovascular disease, for example, that could prevent their participation in the aerobic training of the intervention. So these 60 participants were then randomly allocated into 2 equal groups, a control group and an exercise group, with a 1-to-1 ratio, so 30 participants in one, 30 in the other. And each group received treatment 3 times a week for 12 weeks in total. The control group received standard of care physical therapy for 1 hour, and this included strengthening exercises, balance and coordination exercises, as well as gait training exercises. And then for the exercise group, they also received this standard of care physical therapy, but this time only for 30 minutes. And then it was followed by 30 minutes of moderate intensity continuous exercise on a bicycle ergometer. And within these 30 minutes, a 5-minute warm up and a 5-minute cool down were also provided. And it's also important to note that in the first week, children biked at 40 to 50% of their age predicted max heart rate. And then by the second week, this intensity was increased to 70% of their max heart rate, and then this was maintained throughout the rest of the program. In terms of measuring cognitive function, the flanker test and the Stroop test were used to assess inhibitory control of executive function pre-intervention, at baseline, and again post-intervention. So it used this pre-test, post-test design that we've talked about. These performance tests were also conducted by researchers not involved in the actual training intervention. And I'm sure many of you are familiar with the flanker test and the Stroop test by now, but as a little overview, the flanker test consisted of 20 trials presented with an array of arrows that were arranged horizontally and shown in the same direction, so that would be the congruent condition, or they had a different orientation relative to the middle arrow, so that would be the incongruent condition. And here, children were asked to identify the middle arrow's direction by pressing either the right or the left button on the keyboard quickly and accurately as possible to determine reaction time. And then for the Stroop test, it was used to measure selective attention, cognitive flexibility, and ability to inhibit cognitive interference. And participants were presented with words of color names, but were asked to identify the ink color. And similar to the flanker test, the Stroop test also has a congruent condition. So this is when the ink color matches the name of the word, and an incongruent condition, so when the ink color doesn't match the name of the word. And children were asked to identify the ink color by pressing the first letter of the specified color as quickly and accurately as possible to again determine reaction time.
And just as a recap, this study again looked at a total of 60 children, all with left-sided hemiplegic cerebral palsy, and they found there to be no statistically significant differences in baseline characteristics between the aerobic and the control group, as well as no adverse effects from either group as well. They used the flanker and the Stroop tasks and had a statistically significant interaction of treatment and the time across the groups. Now, looking at the between group comparisons, they found to be no significant differences in pretreatment values between groups and across all the conditions. They also found no significant differences in the post-treatment values between the aerobic exercise group and the control group during the flanker and Stroop incongruent reaction times. But the aerobic exercise group saw a significant improvement compared to the control group in the post-treatment flanker and Stroop response accuracy. They also found a significant decreases in Stroop and flanker congruent reaction time in the aerobic exercise group, but this was not seen in the control group. All in all, there was some improvement in inhibitory control of executive functioning from aerobic exercise, but this is not considered to be statistically significant. Now, moving on to the within group comparison in the control group, when we compare pre and post intervention results, looking at the control group, they didn't show any statistically significant increase in the flanker or the Stroop response accuracy. There was also no significant decrease in reaction time between the pre and the post intervention results for the Stroop and flanker incongruent and congruent tasks. Specifically, they showed us that standard physiotherapy had no significant effect on inhibitory control of executive functioning, specifically in the control group. Now, specifically looking at the within group comparisons in the aerobic exercise group, when comparing the pre and the post intervention results, there is found to be a statistically significant increase in both the Stroop and the flanker response accuracy. There is also found to be a statistically significant decrease in both the pre and the post treatment reaction times in both of the congruent and incongruent tasks. This overall supported the improvement in inhibitory control of executive functioning in the aerobic exercise group.
We have to remember why the study was performed. Impairment in executive function is one of the primary challenges that children with cerebral palsy face that can significantly limit functional independence and reduce their quality of life. As mentioned, this study examined children ages 7 to 11 years old with left-sided hemiplegic cerebral palsy, which indicates insult to the right hemisphere. The patient population was chosen because damage to the right hemisphere is one of the most frequent deficits that lead to impairment or loss of ability to react to sensory stimuli.
The population of 7 to 11-year-olds was chosen intentionally, as this marks a critical time of development for executive function. As discussed, the results suggest that aerobic exercise training improves inhibitory control. The improvement was indicated by both the increase in response accuracy percentage as well as a decrease in congruent reaction times in both cognitive tests. There was no changes in incongruent reaction times, with no difference between groups. These findings are consistent with many previous studies showing cognitive improvements post-exercise in multiple different populations. It was hypothesized that the lack of change in incongruent times may be due to the increased difficulty of these tests, which allows us to think about this selective attention theory. It explains that the brain requires greater attention to recognize colors compared to words. Therefore, the added need for attention could explain why 30 minutes was not enough continuous aerobic exercise for these congruent times, but not the incongruent times. This poses the question that if aerobic exercise could improve incongruent times, what fit principle could be changed, or would a different type of exercise be beneficial altogether?
There are multiple strengths from the study that we can explore. Firstly, this study was a single-blinded randomized control trial. The researcher didn't know which participants were part of which group, reducing possible bias that could have been slipped in. There was also established inclusion as well as exclusion criteria for participants, as Lauren mentioned before. There were also very clear parameters for the defined control group, which received only 60 minutes of physiotherapy compared to the aerobic exercise group, which received 30 minutes of physiotherapy and 30 minutes of aerobic exercise. The study also had a between-group comparison, which is important to avoid learning effects, as well as practice or carryover effects, and decreases fatigue from doing all the interventions. The within subjects was also a benefit, as it reduced the impact of individual differences such as fitness level or cognitive impairment.
Like with all studies, we do have to consider a few limitations. First of all, only children who scored 28 or above on the pediatric symptom checklist were included. This makes it unclear whether the results would be different for children who scored lower, and therefore we can't generalize the results. Secondly, the aerobic exercise group was slightly older and had a higher school grade, although baseline results were not different. But given the smaller sample size, this could have amplified practice effects unrelated to the intervention. Also, there were no cardiopulmonary tests to determine the true maximum heart rate values, so the exercise intensity prescription might not have been sufficient for all participants. Also, the indication that the aerobic exercise was effective was only derived from the change in inhibitory control because there was no cardiopulmonary test involved. The cognitive tests also do pose their own limits, such as inadequate normative data, presence of practice effects, and limited validity. They also require a certain cognitive and motor skill baseline, which could have been challenging for this sample. There was also no objective measurement of the brain regions to help support the claims of executive function, and we have to consider some confounding variables, such as both groups did receive standard of care, so we can't fully decipher that aerobic exercise was the only cause of change in our intervention.
Our study explored the role of aerobic exercise in enhancing executive function, specifically inhibitory control, in children with hemiplegic cerebral palsy. This research directly connects to some key concepts that we've talked about in class. First off, our study incorporates two well-known executive function paradigms, the Erickson-Flanker test and the Stroop-Color word test. These are two response inhibition tests that require an individual to suppress irrelevant information in order to focus on the task at hand. In our study, these paradigms were used to measure both reaction time and accuracy, providing an objective indicator of cognitive improvement. Secondly, another key connection to the class material is the role of exercise intensity and timing and its influence on cognitive function. From the research, we know that if there's a delay in testing following an exercise intervention concluding, the greatest positive benefits are seen when the exercise is performed at a high intensity. Finally, our study follows a single-blinded randomized control trial, and it uses a between-subjects design with a pre-test, post-test measure in order to assess cognitive changes. This is a rigorous methodology that allows researchers to evaluate the effects of aerobic exercise on cognitive function. While our study provided valuable insights, several modifications could be made to enhance the impact. These are just some of the ones that we came up with. One of the key changes that we would make would be extending the follow-up period to determine if these observed cognitive benefits persist over time and also see how long they remain after exercise. Another area for improvement is examining exercise intensity and a dose-response relationship. We would want to look at if greater exercise intensities lead to even more improvements in executive function. The literature suggests that high-intensity exercises can increase gray matter volume and brain activity, but there also are potential risks for pushing the intensity levels too high, especially in individuals with cerebral palsy. Additionally, we would have liked to have an objective measurement for measuring the underlying neurophysiological mechanisms, as these weren't explored in our study. Factors such as neurogenesis, brain derived neurotrophic factor, and cerebral blood flow play a crucial role in cognitive enhancement. Studies have shown that increasing BDNF levels leads to neurogenesis and neuronal maintenance, which does support cognitive functions, particularly in the regions of the brain that support learning and memory. For example, a Hodding et al. Study from 2016 demonstrated that BDNF levels rise following exercise, which would lead to cognitive improvements. Therefore, these are some things that we think could have been done to improve the study. As we wrap up our discussion here, let's just take a brief moment to think about the future direction of research in this area. This slide here highlights some key guiding questions that can help shape upcoming studies. First, we might ask, how would the results have changed if the exercise intervention was modified itself? Maybe different types of aerobic exercise could have been used, varying intensities, or even integrating resistance training. Secondly, duration is a crucial factor, with research suggesting that interventions lasting longer than 6 months tend to produce the most significant improvements. So, how would extending the program duration impact executive function? Another important avenue to explore is whether aerobic exercise can also enhance other cognitive and executive function areas, such as maybe enhancing our working memory or our cognitive flexibility. And lastly, this study focused on children with hemiplegic cerebral palsy. However, what about older youth and adults? We would like to see this study done in different populations and different ages so that we can improve the generalizability of the findings. The findings from our study have significant real-world implications, particularly in the rehabilitation and the educational settings. One of the most practical applications is integrating aerobic exercise into physical therapy programs. This can help children with cerebral palsy improve both their executive function and their motor skills simultaneously. By making exercise a routine part of therapy, clinicians can enhance the cognitive function and physical outcomes. Beyond the clinical setting, schools can also implement exercise-based interventions to support cognitive development in children with cerebral palsy at schools. Short, brief bouts of exercise can enhance the learning and memory, making this a feasible strategy for educators to help support students. Additionally, healthcare providers can also work with families and integrate aerobic exercise into a child's daily routine. Using the families can help to make sure that we sustain the practice of this aerobic exercise. Overall, our study highlights the potential of aerobic exercise as a low cost, accessible intervention to enhance the executive function, specifically inhibitory control, in children with cerebral palsy. Thank you for listening, and we really hope you enjoyed our presentation and learned about the benefits of aerobic exercise on executive function, specifically inhibitory control, in children with hemiplegic cerebral palsy.